There we go. So happy to have everybody on the call today. I'm going to pass it over straight to my Emily to start. Is that right? Nope. Brett?
No, Brett is going to start, but I'll start sharing my screen.
Doing very well today. Sorry, guys. Brett, handing over to you to start.
Was I sharing the right thing?
Let me share my one. Makes it easier, and I get my notes at the same time.
Okay, I'm sharing my screen right now, but you can still open yours on your computer without sharing.
No, that's fine. Okay, great. Thank you very much, everyone. Thank you very much for the opportunity to speak today. It's been really good to see the IOA network grow since the Ebola outbreaks in Eastern DRC and Uganda. Of course, we were integrally involved in those, and lost 2 years of my life on those Ebola outbreaks, consecutive outbreaks. But it's really good to see this network sort of flourish from such a nasty disaster. But today, trying to take a different tact, talking about this collaborative surveillance concept paper, which was just launched by our division, and give you a little bit more background of what it is about, how it came about, I guess, and what sort of our next steps in terms of thinking going forward will be. So without further ado, we'll get started. So next slide, please, Marie-Emily. This I don't need to really say much about from this group, but essentially we need to be very mindful that emergencies are really increasing as a very dangerous global pattern going on, increasing in complexity, increasing in severity, increasing in the urgency of our response. And there's really many challenges here with regards to how we are looking at these emergencies. There is a sort of a very bad misnomer in terms of, like, for example, pandemics being once in a lifetime events, but the reality is we've had infectious disease outbreaks, multinational, very large scale outbreaks happening almost as a monthly event, if not weekly. Natural disasters are occurring, and then some very scary statistics. There's been a natural disaster every single day for the last 50 years. And those disasters are increasing in severity as a result of climate change and other factors. Record numbers of people requiring humanitarian assistance as a result of very long, prolonged conflicts, but a number of other crises really driving the need for some more concrete action within the health emergency space, but also thinking about how are we approaching systems development, realizing that really for many countries, peacetime is no longer an option for doing preparedness. You're almost using the response efforts towards strengthening systems. Next slide, please. So during the course of the last year plus, we've had a series of member state-led initiatives that have emerged. And this 10 proposals to build a safer world was tabled at the last World Health Assembly, not the one last week, but the during 2022, as a means of bringing together all of these different initiatives, a framework of really bringing together a number of governance, financing, and system-led initiatives towards building this sort of global architecture. And it's been framed as the HEPR, Health Emergency Preparedness, Response and Resilience Framework. But that has been sort of further discussed within all the consecutive WHO Executive Board meetings, and it was further discussed at this last World Health Assembly. And we're still digesting a lot of the messages and the information we've gotten back from member states on that grounds. So very briefly, HEPR encompasses this sort of governance space, which is a number of initiatives, sort of series of principles, a series of information, but there's two really flagship initiatives that start driving forward the needle in terms of governance, which is the IHR revisions ongoing, as well as the INB, so the International Negotiating Body, discussions around development of a pandemic accord or similar instrument. Within the financing space, and this is a space that's gaining a lot of attention at the moment, rightly so, trying to identify more sustainable financing for preparedness. The pandemic fund is, of course, that big one that everyone's on everyone's lips at the moment, and that has really prioritized 3 spaces: surveillance, laboratory, workforce, with about 300 million proposed investments over the course of the next year in those 3 spaces. But those are only, I guess, a small fraction of what is going to be needed towards strengthening national investment plans. And there is a number of concerted efforts ongoing, supported by WHO, but a number of partners as well, towards sort of more sustainable financing and being met as well by national governments, so that things like surveillance are really thought part and parcel of domestic financing and moving forward. The third big branch here is the Health Emergency Preparedness and Response Framework. It's been a series of documents, and quite recently we published the Strengthening Health Emergency Preparedness Response and Resilience. It was very much a similar document that was tabled at the last World Health Assembly, and this really describes what it is in further detail, describes each of the, we call them components, there's 5 components, as well as a number of horizontal work streams that are contributing towards the thinking behind this space. Next slide, please. So to really introduce this collaborative surveillance concept, it started off with these countless amounts of recommendations that WHO and partners received during the COVID-19 outbreak and preceding emergencies, all of which really emphasize the need to strengthen national surveillance without exception. And this come from international bodies, expert advisory groups, all independent to WHO. And that drew into the creation of these 5 components. So collaborative surveillance being the first of those, but also including emergency coordination, access to countermeasures, safe and scalable clinical care, community protection. But the prioritization of collaborative surveillance amongst those 5, I think it really highlights how we really hope to move forward in this space, and that, but also prioritizing the local national surveillance as the foundation of this whole global public health security. So I think there's really strong calls on national governments, on institutional organizations to really push forward the surveillance agenda. And off the back of those, over the series of the course of about 7-8 months of intensive working group sessions, we developed this term and this concept called collaborative surveillance. And what that is really a conceptual module, a series of objectives, a series of prioritized capabilities and sub-capabilities, enabling factors to push forward this area of strengthening capacity, but also strengthening collaboration across many different stakeholders in order to enhance public health intelligence, or in order to enhance what information is getting into the hands of decision makers, so that the right decision making is at all levels, from the individual community to the policymaker to the international person that's deciding who goes in terms of an emergency response. They have the right information at the right time to inform the right decisions. And fortunately, the concept paper got some good attention. It was published quite recently in the last week, and we were lucky enough to get a Lancet commentary included to help promote some of those key concepts. Next slide, please. So what this collaborative surveillance concept really hopes to drive forward is this desire to have every single surveillance actor, every single surveillance stakeholder, doesn't matter if you're driving forward an individual system or a more holistic approach, to acknowledge that any one system cannot answer all the questions. And I'm sure everyone in this group was in a similar situation, facing a policymaker or facing a group to say, and answering a barrage of questions. Certainly during some of the deployments I did during COVID, sitting across the table from a minister for health, you would be answering questions, and more often than not, it wasn't your traditional surveillance approach that would be able to answer them comprehensively. and maybe give you some clues in terms of maybe how many cases we've had today, how many deaths did we have today, what the risk factors were. But when you start talking about things like what variants are circulating, how dangerous are they, are our interventions working, all of these things, you start to realize, hang on, the public health system is not as connected as what it needs to be during an emergency. Next slide, please. So the collaborative surveillance concept aims to really bring this to the fold, this concept of multi-source surveillance, and really emphasize the need to look beyond your traditional integrative disease surveillance approach. Really at the heart of that is the need to acknowledge that given these diverse objectives and these diverse decision maker needs, we cannot rely on one system. It's going to take multiple systems across approaches. The relative importance of each of those approaches also differs over time and context and throughout the emergency cycle. And really what we need to do is promote more holistic thinking in terms of multi-source surveillance, data triangulation, which is really being spearheaded by our regional offices, for example, within the Southeast Asia region and the Western Pacific in terms of multi-source surveillance, by some of our vertical programs in terms of data triangulation, and more recently within sort of the integrative outbreak analytics space as well. This is, I believe this is really at the heart of what we're trying to do with this community of practice. CS, collaborative surveillance, really does not try to disrupt or move the argument around sort of integrative disease surveillance or vertical and specialized programs, but really support each of these. These both have a place in the 21st century surveillance world. Yes, there is a need to integrate where appropriate, but we also need to recognize that the vertical and specialized programs have a lot to bring to the table. So we need to leverage those to the best of our ability. We also need to look at, for example, the within the health space, at least the strength of our health information management system. So there's the routine monitoring, facility monitoring systems, looking at capacity, access, usage of hospital beds, how many oxygen cylinders do we have available, all of those type of things. And to be quite frank, most national governments during COVID-19 were not making public health and social measure decisions based on the number of cases and deaths. It was how full are our hospitals, how are as a health system coping, and not having those systems as closely connected to public health as what we thought they were, meant that often during the COVID-19 pandemic, we were building systems and building connections, which is not the ideal situation to be in. But also now I need to look beyond that in terms of insights and on community dynamics, community behaviors, capabilities, vulnerabilities, to build out the full context and really apply these integrative analytic approaches, and that we're doing so in terms of filling out the picture. And then replicate that across each of the sectors, not necessarily doing it in silos, bringing these sectors together. Of course, there's the traditional One Health sectors, but also thinking beyond those in terms of what it really takes to provide the right decisions, but doing so in an intentional way, because there's also a real danger here in that we bring too much information into the fold, and that we further clouds the message. So doing so in an intentional way, thinking through what your risks are, what your hazards are, what information sources we potentially pre-position, and where can we access those right collaborations to inform what it is we need to do in terms of the public health space. Next slide, please. For this group particularly, I think this slide is of relevance. Looking at integrative disease surveillance, looking at all the other sort of initiatives in the space, IDSR, etc., you quickly come to a realization that there is no universal definition of integration. There's no universal definition of IDS, and there is a very different very different interpretations of that when you speak to various individuals. So with the collaborative surveillance concept, it was really an intentional effort to bring a bit more of a modern take on this, that we don't necessarily need to always be talking about integration in terms of the hard-coded data sharing across the board. or in terms of the sort of building common systems, that has its place, that needs to happen where appropriate. But integration can also mean data information sharing across systems and dimensions. We'll talk about those dimensions in a second. For mutual benefit, sharing and integration of capacities. One of the, I think, strong lessons for governments during the pandemic is that capacities that they thought they had and they could leverage during emergencies all of a sudden became a barrier. Laboratory equipment that couldn't be repurposed for doing, for example, COVID tests was a strong example of that. And then the fourth one there is really a call for more open communication of surveillance findings. And this also enables all stakeholders, doesn't matter if you're an individual, if a member of the public or an international organization, but looking at more open communication of surveillance findings and building the right systems, building right feedback loops in terms of exchanging that intelligence that has been generated by others, but also mopping up all the information that we need to be able to further some decision making at all levels. Next slide, please. So the collaborative surveillance concept really rests on these two, the sort of two fundamental sort of conceptual frames. First is the need to not only increase capacity, and this is what the sort of desire has been over the last 20, 30 years in the public health space in terms of when you're talking surveillance, it's always about increasing workforce, systems, capacities, tools. This is still needed. There's still a lot of work to do here, but at the same time, we need to be thinking about how do we sort of intentionally strengthen our collaboration. And so what the working group decided was these 4 critical dimensions of thinking about how we are looking at our collaborations. First of all, across diseases and threat systems. So these are the respective surveillance systems, bringing collaboration across these groups. Across sectors, and this is a traditional one, multi-sectoral engagements, but not only thinking about, for example, the traditional sectors, not only thinking about sort of one health space, but bringing in different fields of expertise, bringing in different groups, bringing in private sector, civil society, etc., to be able to really bring that sort of multi-dimensional views. Collaboration across the emergency cycle, and there's a real danger here that we're trying to progressively undo, is that surveillance is always focusing on one objective, that's detection, detection, detection. But the reality is, once we've detected an outbreak, surveillance does need to flex, needs to adapt to be able to respond to those emergencies. And if you think about sort of the majority of our efforts during COVID, they were on the response phase and now on the recovery phase. But if all our sort of surveillance systems are more equipped to meet the detection objective, we're falling short. So it's an acknowledgement that we need to be hitting across the emergency cycle, as well as the routine monitoring phases. And then the fourth one is a classical one across the geographical levels. But here we've made an intentional effort to say, first of all, local information for local analysis, for local decision making. And I believe, again, that's really goes hand in hand with some of the principles that the IOA initiative is trying to promote. Next slide. So the second conceptual module is an acknowledgement that every country is different. Every country is unique. Some countries are extremely good at surveillance, but their collaboration may be a little bit lacking. Some countries are really good at collaboration, but they might not have the capacity necessarily to do all the surveillance objectives. And there's a suite of countries, or most countries are somewhere in between the spectrum. So every country really needs to find their own path in this. And with the capabilities that are being proposed, the sub-capabilities, the objectives, the desire here is these are options, I guess, for countries to think through. And then there needs to be some sort of assessment of on what level of these sort of two axes, and what is the surveillance maturity looking like, looking across systems, looking at across capacities. And countries are going to need to find their own path, make certain priorities that are right for them in terms of what systems, what collaboration efforts they want to strengthen, and how best to do that. and feed that into their national action plans, national investment plans, towards sort of pushing forward that needle, but all sort of taking a progressive stance in terms of first building some sort of foundational collaborative surveillance capabilities, and ultimately driving towards that end goal of optimized decision making. And that across the collaborative surveillance concept, that decision making is always the thing that we came back to and say, well, if we're prioritizing some sort of capability, system, tool, whatever it is it actually helping us move that end goal forward? And the next sort of phase of collaborative surveillance, we hope to further our thinking around this space, to really potentially build out some tools, pilot them in various countries to be able to help assess the sort of surveillance maturity in concert potentially with some of the more classical monitoring and evaluation tools that are available. Don't want to replace those, and we certainly don't want to be creating another monitoring and evaluation tool or any sort of international data collection with regards to the sort of surveillance maturity space. Next slide. And then finally, the collaborative surveillance concept promotes these three core objectives. So the first objective, first and foremost, focuses on national integrative disease threat and vulnerability surveillance. And then there's an intentional effort here to focus first on the routine surveillance capacity. Again, the acknowledgement that we cannot always go into an emergency, implement a contingency tool, and then that results in weakening of the routine national capacities. There's an effort here to switch gears and think, okay, if we're going into an emergency, that first and foremost, we're thinking about using the routine capacities to be able to respond to that emergency. And any strengthening effort is feeding back into that system, using the emergencies as sort of catalysts in order to strengthen the national capacities. The second objective is really focused on the lab side of things. So looking at both the traditional lab capacities, thinking about some of the more modern technologies with regards to genomic surveillance and how that feeds into the informed decision-making processes, but then also looking a little bit both to the present and the future around, for example, point of care testing. How is the data and all the information and the knowledge that's being generated by those tests going to feed into the national structures moving forward? And the third objective is really bringing all of these capabilities together. So those dimensions of collaboration are not going to happen by themselves. Beyond the memorandums of understanding, beyond the agreements, etc., we're going to need the systems, the tools, the infrastructure, the people, the networks. All of that needs to be in place in order to foster that collaboration and make it sustainable, and ultimately ending towards that goal of better decisions. And in the concept paper, I'm not going to go through them all now. There's a lot more discussion around each of these objectives, each of the capabilities that leads onto these objectives, as well as the number of enabling factors that will be necessary for this to all be in place. Next slide. So just to conclude, thus far, what this concept paper is a culmination of the work on the sort of the design phase of this collaborative surveillance concept. It defines the what, it does not define the how. And this is where we now need to move thinking forward. What are the practical tools to support countries with the implementation of the concept in order to, for example, if in a certain region, you're thinking more in terms of IDS, IDSR, how does the collaborative surveillance concept promote that? Another region may be more focusing on sort of multi-source surveillance. How does the collaborative surveillance help move that agenda forward? So there's going to be, I guess, a suite of tools. Some will be global, some will be very regional specific. But this, we also want to sort of help define what is it moving forward. So if this group has some concrete ideas of, okay, for example, specific tools or specific support needs that need to be in place for implementing collaborative surveillance in the IOA context, I think there is scope to consider those moving forward. And it really also is a core goal. It's in our WHO Division of Health Emergency Intelligence and Surveillance Systems activities goal, all the strategies that are going forward. So there's going to be a number of initiatives coming out of our division towards helping to push that forward, but also hoping to work with partners a lot more intentionally about how we progress that. And final slide is just there, and we'll share the slides, of course, after the presentation. But there's the concept paper, direct links, but also the broader HEPR space, which discusses at the high level what each of those 5 subsystems are, and how this fits into the broader global agenda. And just to acknowledge that there was many individuals who've inputted onto this in the last 7 months, and it does build on a lot of predating work that has happened across the board. So thank you very much, and over to you, Maria-Emily.
Thanks, Brett. I think Esther is going to share. Esther, I'm not sure, do you want us to give a presentation now, or do you want a short Q&A to Brett?
I think it would be good to follow up now first with your slides, and then or our slides, and then we have the discussion, including the questions to Brett.
Sure. So there you go. I believe you can see. So we tried to put those. Hi everyone. I'm Maria-Emily. Sorry. I actually work in the same department as Brett, but wasn't involved. I mean, didn't involve myself or wasn't involved in the collaborative surveillance work, but Brett is a great supporter of IOA in WHO. So we thought it would be interesting to showcase collaborative surveillance today, and that work that was done by this group, and to show how IOA fits and aligns with the collaborative surveillance conceptual model. So you might have seen that before I arrived to the slides, there were some annex slides to Brett's presentation that detail a bit more those 3 objectives that he just presented. And those we see how IOA fits those objectives, especially objective 3, that is around the collaborative approaches for event detection, risk assessment, and response monitoring. But it also does fit into the objective 1, where we talk about national integrated disease threat and vulnerability surveillance. So as you all know very well, IOA, leverages local surveillance capacities, is locally led and implemented, and does use community source data. That we showcase that actually in many of our field exchanges. We showcase that in the field exchange, Volume 4 and EWAR, and IOA with MSF's example of the T-Team's surveillance system in Somali region, and of the Somali Red Cross and Red Crescent on community source data usage. There's also the use of healthcare surveys in Ebola outbreak. So whether community source data that are routinely collected or that are collected in an ad hoc manner, depending on the context and the disease. We believe that maybe IOA can propose alternatives to more traditional surveillance mechanisms and tools, and could also challenge the collaborative surveillance framework, conceptual modes or surveillance existing, because some tools might not exist, and some surveillance, alternative surveillance mechanisms may need to be developed. So I have to stop saying WHO. IOA also convenes local, national, regional, multi-sectoral actors, and promotes that collaboration between all of those actors and those disciplines. It produces multidisciplinary information to inform locally led response activities. So altogether, we believe that this contextualizations, local anchor, agility and sustainability, it really fits the collaborative surveillance principles. And just as a reminder of really how during acute health emergencies, IOA is triggered and leverages all of the available information. We're so lucky to have this new animation that was released last week or this week that we will be showing. You're very lucky to see it today live on this IOA network call. So.
How an integrated outbreak analytics or IOA cell answers operational
Sorry, I keep doing that all the time.
questions. In a public health emergency, the Ministry of Health will often coordinate a response by setting up response pillars. These are usually for surveillance, risk communication and community engagement, or RCCE, case management, vaccination, if vaccinations are available for the outbreak, continuity of essential services, logistics, and the Pillar for Infection Prevention and Control, or IPC, and water sanitation and hygiene, or WASH. The Ministry of Health may decide to set up an IOA cell to better coordinate analytics actors for an improved understanding of the dynamics of public health emergencies and their impacts on communities. An IOA cell brings outbreak response actors together to generate evidence to improve public health response. These may include epidemiologists, data scientists, social scientists, mathematical modelers, One Health experts, medical anthropologists, and experts relevant to the unfolding public health emergency. Such experts will be provided by national academic institutions, national or international NGOs, civil society, and UN agencies. The IOA cell is often led by the Ministry of Health. To set up an IOA cell, terms of reference are developed by the Ministry of Health and shared with IOA cell partners. The terms of reference include objectives, governance, ways of working, and communication channels. The cell often performs 4 main activities. The first activity is to support emergency coordination to collate operational or trigger questions that are relevant to understanding the public health emergency and can be answered through IOA. A rapid protocol will be developed for each question. The second activity is to provide timely quality data collection, management, and analyses following the agreed protocol, and mobilizing the relevant expertise to respond to the trigger questions. The third activity is for the IOA cell to support response actors in the co-development of recommended actions based on IOA evidence. To do this, the IOA cell will present all analyses and findings to the different pillars and develop recommended actions together. Finally, the IOA cell will monitor these recommended actions by location over time to see how they have been delivered and what difference they have made. For example, in the first months of an Ebola outbreak, over 60% of Ebola cases were seeking treatment more than 5 days after developing symptoms. This resulted in greater case fatality ratios compared with those seeking treatment early, after 2 days. Knowing that early treatment for Ebola results in greater survival, this created a trigger question for the IOA cell to investigate. What factors contribute to early and late isolation? The Ministry of Health mobilized the IOA cell to develop a protocol to address this question. Existing data were first reviewed, such as spatial distribution of cases provided by the surveillance pillar, to see if the observations were location-specific, and health information systems data provided by the continuity of essential services pillar, to see if there were any significant decrease in routine healthcare service use, indicating a general reduction in health-seeking behavior. Social scientists within the IOA cell conducted in-depth illness narratives and verbal autopsies with cases who were categorized as early or late isolation cases. Interview data were coded and analyzed. As some of the findings highlighted specific barriers regarding detection of cases and symptoms, data from healthcare worker surveys conducted by the IOA cell and IPC pillar scorecards were also brought into the analysis. Data from the narratives found that nearly all late cases did not recognize their first symptoms as possible Ebola, and that early cases believed that with treatment they could survive the disease. Surveys also highlighted that healthcare workers had limited knowledge of the preliminary and most common Ebola symptoms. For example, although more than half of healthcare workers reported bleeding as a symptom of Ebola, it was only present in a small number of the cases. But few recognized body aches as a symptom of Ebola, which was one of the most common symptoms. All these different data sets and analyses help the IOA cell to see the whole picture and solve the puzzle regarding factors which could improve or impede early isolation. The surveillance, RCCE and IPC WASH pillars use this information to take actions to improve early care seeking among cases, such as training healthcare workers on Ebola symptoms and scaling up health promotion messages on improved survival rates and early treatment seeking. To find out more about IOA, please select one of these videos.
I'm not going to show an additional video.
No.
That was it to conclude this presentation. Over to you, Esther. I'll stop sharing my screen.
Yeah, thanks both Brett and Marie-Amélie, also for the further clarifications on the links with IOA. I think in brief, because Brett, you made an interesting question at one stage where you said it would be good to hear also more about how IOA basically can be supported in implementing collaborative surveillance. But I think it's almost the other way around, where one can also say that with the examples we've been showing also in this video, how we provide, I think with IOA, an example of how to facilitate capacity strengthening, I think, with leveraging new data sources, among others, community source data, which we often find difficult to integrate in a sustainable way in routine surveillance, but during outbreaks can be set up ad hoc, for example, but also by increasing the collaborations and enforcing collaborations in the emergency cycle. So I think that is an interesting point to further discuss about today. I will first kind of leave the floor open to the people in the chat, whether they have any questions for Brett, for Marie-Amélie, for any comments to make around the links between IOA and participatory surveillance. Have a go. Floor is open. Silence. No questions for Brett either? Ah, yeah, there's one.
It's
yeah.
Sorry.
Hey, Christine.
Hey, good morning, everyone. Thank you, Brett. I mean, I've looked at the document. It's a fantastic move. The one thing I really like in your sorry, my name is Christine Dubré. I work for the CDC, and I'm with the Global Rapid Response Team, and I'm part of the IOA core team. Sorry, I came late on the call, some connection issues here. Just what I wanted to say, one slide, because I was just thinking about that when the slide came out, was your slide about collaboration versus capacity. I have to say one thing, that we are asking what is the impact of the response, etc., at the local level, at the community level. It's very, very important. That's most of the work I've done. I worked with communities, but I think one thing that I've learned to understand better and better as well is what is the impact of an outbreak at the geopolitical level, economic level for the country. Because I think of what we see during responses when we have the impression that a country is not collaborating, doesn't want to take some action that would help and basically save lives sometimes. I think a lot is motivated also by the social geopolitical aspect of everything at the country level. Is it what's the impact for the whole company? What's the impact for tourism, etc., etc.? And I think even if we really want to work at the community level and at the health system level, etc., as scientists, we need to understand that better and better. And even when we do we start talking about implementing this new concept and this new document, I think it would be very important to understand what countries have to say about that as well. Because at the end of the day, if we want to have a positive impact at the community level, we need to have the collaboration from the country. And I will stop there. It's not a question, it's a comment.
Thank you, Christine. Brett, did you want to reply to that maybe briefly?
I'm happy, as you like, to take a couple of questions and comments and things, but it's absolutely, you're 100% right. It's absolutely essential. And one thing that we insisted with this collaborative surveillance concept is it's not collaboration for the benefit of WHO, or it's not collaboration for the benefit of any given partner, and it's not collaboration for the benefit of a rich country doing surveillance on a poor country. It's absolutely the opposite. It's collaboration first and foremost for at the local level, and thinking about sort of subnational collaboration, thinking about national collaboration in country, that needs to be in place first. So if you think about cross sectors, if you think about private partnerships, private-public partnerships, if you think about sort of partnerships with civil society, et cetera, that's all going to happen at the local level. It's not going to happen by some international actor, but it's that local level sort of information generation, decision-making response that's going to drive things forward. On the international space, I don't think we could talk about collaboration without broaching that topic. And there's one section within that concept paper that talks about building a culture of trust. And a big part of that is ensuring that whatever information exchange, whatever data exchange, it's being done so for mutual benefit. So that if we're, and I'm going to use the famous example, and something that I experienced firsthand was the border closures in South Africa as a result of sharing variant sequences. So with that, I mean, we're not going to be pretending to say, well, we're going to solve that issue, that sort of global crisis issue here. But it's to really foster more discussion, more information sharing, more insights, to understand that any action that results of information sharing needs to be done in a way that is going to be benefiting the end goal. There's still going to be travel restrictions that we have to face it that are going to be put in place. We're not going to stop that. But at the same time, does, for example, international reporting of an event carry some sort of weight in terms of additional resources for that country, access to countermeasures, et cetera, et cetera. There's many examples, good examples of what could be done to encourage that sort of mutual benefit. And that's talking about sort of international geopolitics, but even at the local level, so information that's sharing across different stakeholders at the local level, that also needs to be done at a mutual benefit. So that, for example, that it's not a one-way information flow, that the doctor that's collecting the specimen, the nurse that's filling in the forms, et cetera, they are also receiving some feedback of what is happening within the surveillance system. So that mutual benefit applies throughout, and the sort of creating that culture of trust is not going to happen very easily, but it's something that we all need to work towards, and be mindful that there's real risks that deteriorates very, very quickly with actions that are taken as a result of an emergency. So yeah, it's a tricky topic.
I like if you allow me, one thing I would say, and then I will stop, but the culture of trust, it's easier to build outside of an emergency. During an emergency, it's extremely difficult. And I think that's what happens often. And that's why when we say we need to talk with the country to prepare the countries, etc., that's when we will build this culture of trust. I've been working a lot with Simon and others on Ebola outbreaks, and I think it's difficult to build this culture of trust in the middle of an outbreak. And I think that is part of the work we need to do ahead of time. Anyway, I'll stop there, but thank you very much. That was great.
Any other questions? No further questions. I actually might have one, Brett, because you were also saying, right, that we generally tend to think around surveillance systems maybe not often enough in how we're leveraging them during outbreaks, and that is something that collaborative surveillance is also trying to further support. Can you maybe elaborate a little bit further on how you see that, and notably on the local level, what kind of thoughts you had there, going back maybe to among others, the 4 dimensions of collaborations that that collaborative surveillance is emphasizing on? Because everything is quite conceptual, right? So it's nice to maybe get a bit more of
some concrete examples of that.
Yeah.
So I mean, it's the sad reality that we face, that in an emergency, and it's not necessarily the international response teams that are coming into emergency that are advocating, but often the sort of the local government, that instead of using an existing surveillance system in place, they'll quickly look to some sort of contingency tools, be it SORMAS, Go Data, whatever. They're sort of doing it for any sort of data collection that's happening. There is a need for that in places. There is a need for those contingency tools in certain circumstances, but it needs to be done in a very intentional way, in that it's usually has to happen before an emergency. That if you want to have a contingency tool deployed properly, have some of that sort of training in place beforehand. But also during an emergency, if you have a massive natural disaster and you need to deploy e-wars in a box, or you have a large-scale humanitarian emergency and you want to do a health service survey using, for example, the HERAMS tool, these need to be done in a very mindful way. And first ask the question, can we utilize an existing resource capacity to be able to do that? Is the existing system, be it DHIS2 or whatever, in place? Can we figure out a way in which we can leverage that? Because in essence, we've got a skilled workforce in place that knows how to use that tool and promote it first. If the answer is no, well, how then, for example, is our contingency tool that was deployed going to feed back into that routine surveillance function as well? And that whatever capacity is built is then sort of fed back into building that routine capacity, rather than sort of deploying mobile tools all the time. Is there a way to boost, use the emergency, use the additional funding that's coming in, using additional resources, the expertise that is coming in to be able to do that? And I think IOA has a huge role to play in that space. So if you're establishing a cell, is that cell advocating for using a contingency tool, or is there an existing tool in place in country that can be leveraged? And it doesn't matter if it's a simple modeling approach, or is it a real sort of tangible software, anything. You need to look first in terms of what is existing and what capacities can we leverage first to be able to do that. And I think that's really sort of promoting that routine surveillance capacity strengthening, but also strengthening of those routine capacities in an intentional way to be able to be flexibly responding to emergencies is also quite critical, because there's a reason for these contingency tools coming in place, because often the existing surveillance is either not equipped to surge, or it is it's not sort of flexible enough to add additional variables, or just the data collection modality is completely discordant with what the information is needed to generate during an emergency. So it doesn't fully answer your question in terms of all those different dimensions, but it's just sort of one practical example of thinking through routine capacity strengthening towards also meeting some emergency response objectives.
Yeah, no, very clear. No, and actually, and personally, I think there's also this because I think within IOA there we haven't been using that type of example I'm going to mention now, but there is the example of, for example, trying to see these healthcare worker surveys. That's not necessarily a tool, but or the type of tool I think you're referring to, but it is kind of a protocol which can be then, whenever there is an outbreak and you try to further understanding, to leverage, for example, those kind of additional data collections as well, which are triggered by an outbreak. And I think with COVID, what we've seen with the REACT study, with COVID, with the COMICS, the community level kind of data collections, having some kind of pre-thinking before an outbreak happens, what type of data do we need during outbreaks that can enhance existing surveillance, and we have on the top of our minds to further basically our understanding, but don't necessarily need to be routinely collected. I think those are also interesting mechanisms to think around, right? How to enhance data collection at a community level with triggered surveillance more kind of ad hoc surveillance mechanisms. But that's kind of a personal thought. Rachel, I see you have a question.
Yes, thank you so much. I hope you can hear me okay. I guess let me know if you can't hear me, but thank you for the presentation. It's fantastic. And just on that last point, I think we couldn't be in more agreement in terms of some of the successes we've seen, for example, with the approach to community-based surveillance within different Red Cross or Red Crescent national societies. Some of the longer efforts that have gone into establishing these more systematic protocols with ministries of health or government officials that are really put in place so that it does establish a routine and systematic way to link the community level information with the national surveillance system during non-emergency and non-outbreak times, and really seeing that as an option to build on, hopefully in the future, for surging during an emergency and then scaling back down. We've seen this work especially well in areas where we have this kind of ongoing as a routine activity. And when there is an emergency or there is an outbreak, we're able to then rely on, there's a pre-established protocol if we need to expand to new areas. We can use that pre-established protocol. I think it's a really interesting concept and a really important model. And I think it's fantastic, right? You touched on a lot of key points that we've been seeing over and over again that hopefully can continue to link to as well. So just to add that as an example of an approach, it can be a tool. It's not only a tool though, it's more of a systematic approach and agreement protocol. But thanks.
Thank you very much, Rachel. And it's fantastic. I think with regards to the CBS as sort of a routine activity, absolutely, and sort of in every country I've worked in, it's been that case that some of the most actionable intelligence comes not through the traditional surveillance approaches, but through very well-placed community informants, very well-placed community health workers, and not only focusing on the detection objective, but focusing on other sort of critical needs and critical functions throughout the emergency cycle. So on that point, when you're thinking about CBS, but you think about any surveillance approach, and I think this applies for anyone that's got anything to do with surveillance, is having very well-defined and communicated objectives of what this surveillance approach can and can't deliver. What of the suite of surveillance objectives that are necessary does this component contribute, and measuring and documenting and sharing how effective is that surveillance approach in meeting those demands that are being driven by decision makers, and what's the cost effectiveness and cost efficiencies of those systems with regards to any other surveillance approach. And some of the sort of more shiny new tools that are coming in place have a real risk of displacing some of the actual critical core functions that are absolutely needed. And we sort of talk about a new technology such as wastewater surveillance or other forms of environmental surveillance. They have their place, and they can be used in a very constructive way. But if that comes to the detriment of a community-based surveillance, which we would consider absolutely core, we need the evidence to be able to argue for one of these approaches. And the reality is that there is some rationalization that needs to happen. So absolutely encourage everyone thinking about surveillance, thinking about IOA even, how are we documenting, how are we measuring both the effectiveness and the cost efficiency of each of these approaches towards informing that end goal of decision making, because that's something that certainly our group and across the collaborative surveillance concept we're going to be advocating quite heavily for, and looking at, for example, not only for respiratory viruses around the sort of the mosaic framework, what's all the tiles that are necessarily for the mosaic of gastroenteritis, other forms of vector-borne diseases, all those type of things. So what are all those tiles and mosaic needed, and how does something like community-based surveillance fit in? And is it core, or is it an essential add-on if you've got additional capacity to do so? And I'd argue for it to be in the first box, but we need the evidence. So
Okay, we're actually nearing 3 o'clock. I don't see any further hands up, just a thumbs up by Lester, thank you. So without further ado, I think we can close this meeting. Thanks so much, Brett, for further clarifying the concept note and the Lancet accompanying Lancet commentary. Yeah, I see you want to say one more thing. Go ahead.
So I just wanted to thank again for the opportunity, Esther, and all the IOA core team. I did make one point, and sort of just a clarification around sort of not IOA supporting community collaborative surveillance, but if the IOA community has specific needs in place, and you see that as something that perhaps the network is not going to be able to deliver, but would be an idea that you can propose to this sort of wider group. I think we've got lots of political attention. We've got some attention from some key donors and others around the sort of collaborative surveillance concept. And if there's critical needs that going forward that you foresee, do fire them our way. I mean, sort of Marie-Amélie will help direct as well. But if there are those sort of ideas that say, well, this sounds great, but we need this tool to implement it. That's what we want at the end of the day is that, okay, well, how is this going to be translated in terms of action and country action, but supporting existing initiatives. What we absolutely don't want to do is replace any of the core surveillance strategies that are out there. So thank you very much again. Cheers.
Oh, thanks so much for that note. Yeah. Okay. Thanks everyone for being here, and looking forward to the next call in 2 weeks' time.
Thanks, everyone. Have a good weekend.
Thanks, bye.
Good
Thank you
weekend,
very much.
everyone.
Thank you.
Thank you.
Thank you.